We recently published a multi-center retrospective look at outcomes for patients who underwent leukapheresis with the intent to manufacture autologous CD19-directed CAR-T cell therapy, specifically axi-cel. So these were patients with relapsed refractory large cell lymphoma, relapsed refractory primordial or transformed follicular across 17 US centers. It's also notable that these centers had experience with axi-cel, primarily participating in the ZUMA prospective trials. So we had a study cohort size of nearly 300 patients, so 298 who underwent leukapheresis with the intent to manufacture. What was quite striking is that the manufacturing rates were very high, so over 90% of patients who underwent leukapheresis had successful manufacturing and receipt of that cellular therapy. There were a portion of patients that did either die as a result of their progressive lymphoma between the time of leukapheresis before cells were infused. There was one patient who responded to bridging therapy, which other than steroids was not allowed during the ZUMA-1 study and did not ultimately go on to receive cells. And then a small portion of patients who had infection or organ dysfunction that precluded cell infusion. But similar to what was seen in the tightly controlled prospective study of ZUMA-1, a high proportion of patients who undergo leukapheresis had successful manufacturing of cells and infusion of those cells. Also noteworthy is that outside of the confines of a prospective study, this therapy is being prescribed to patients that would have not met the eligibility criteria of ZUMA-1. The majority of the reasons had to do with worse performance status than what was eligible in ZUMA-1, meaning ECOG performance status of 2 or higher, having comorbidities that would have precluded enrollment, including low ejection fraction, elevated or poor renal function, as well as liver enzyme or hepatic function abnormalities. In addition, we saw patients who had had a history of CNS lymphoma or prior allogeneic stem cell transplant, all of which would have excluded them from participating on the ZUMA-1 study. So our study population, approximately 43%, would not have qualified. Despite this, the safety profile looks very similar to what was reported in ZUMA-1, with very similar rates of cytokine release syndrome and neurotoxicity, albeit with higher percentage use of tocilizumab and corticosteroids, which reflects our evolving practices in terms of management of the acute toxicities associated with CAR-T cell therapy. Notable, a third of patients ended up in the ICU, primarily as a result of monitoring or treatment for neurotoxicity. Very few patients died as a result of acute toxicity, so approximately 5% of patients, and those toxicities were either septic shock, one case of HLH, and one case of cerebral edema across this cohort size, again, of nearly 300, which is noteworthy. We have about a year of median follow-up, and with this we see almost identical progression-free survival and early reports of overall survival as was reported in the ZUMA-1. So again, despite this being a potentially sicker, frailer population, the safety and efficacy profile essentially mirrors what was reported with the ZUMA-1 trial, which in my opinion confirms that this is an effective, definitive treatment for patients with relapsed refractory large cell lymphoma. And this can be reproduced across multiple study sites in the US.